Okay, well, we'll make a start in this lecture. As I said, I'm trying to record this lecture so that other people can look at it online as well. But I really want to go through just, as I say, a series of 5 lectures there. They go over about 4 hours, I suppose. But we'll just talk about one thing today, and that's over the 5 lectures, we're going to just cover a background to epidemiology, just basic things about epidemiology and about incidence and prevalence. I hope that all of these lectures will help you in understanding about research, understanding about epidemiology, and understanding about how you design your projects, how you choose topics to design to study, and how you might analyze such projects. So the first one today, we're just going to simply talk about a background to epidemiology and talk about incidence and prevalence and the difference between the two. All right. We'll talk about means and medians and confidence intervals and case control studies and odds ratios in the next lecture. And we'll talk about, in the third lecture, we'll talk about cohort studies and cover randomized trials and relative risk and bias and confounding. So there's a number of different things there. And then in the fourth talk, we'll talk about precision of diagnostic tests, and the way we measure that is with sensitivity and specificity, and a thing called the positive predictive value or the negative predictive value. We'll talk about screening tests and some quality improvement research. And then lastly, we'll talk about ethics in research and some other research processes. So all up, it should help you at least understand the basics of research and understand how you go about doing your projects. I want to first say that in your projects, they don't have to be complicated. I mean, all of this on this slide seems complicated, but your project should be relatively simple. And in some ways, simple projects are the best projects because they're, designed in a simple way. They're answering a specific question, and they're using analytical tools that will answer that question. So the reason why research has so many different tools, like relative risks. Oh, you can't see that. Oh, no, I've moved on, but you can't see it. Oh, I'll just, right. Yeah, look, the main thing I wanted to start with is that the projects that you do, should be relatively simple. They should be targeted around a topic that you enjoy and that you can study. So that's what we'll talk about. Doing research really, there's many steps, but first of all, you have to have an idea or a problem, something that you that you want to study. And most people have got an idea, but turning that into a clear research question is often the most difficult part to start with. But we'll help you do that. Then you have to define your objectives and your hypotheses. Sometimes it's just exploring an issue. Sometimes it's a specific question that you can apply a research type question to. Then you need to do some sort of review of the literature to make sure that the question's not already well answered. It might have been answered by multiple different research projects. And sometimes the research question will have been answered by projects that are not, that are not in PNG or not in this setting. And so it then becomes relevant to do the research in this setting, right? And so just because there's another research project on that particular question doesn't mean you can't study it. But you don't want to be doing what we call redundant research, where you're studying something that someone studied last year in the same setting. At some stage, it's good to learn about either EndNote or some sort of reference manager program. That doesn't have to be done at a immediate postgraduate level. People who are doing doctoral theses or other higher levels of research need to know about that. But it is useful if you can learn about EndNote or even the reference manager system within Word, right? Sometimes there's many different things within Word that you can learn how to do. And I'll show you towards the end how to use Word to create subheadings and create indexes and tables and that sort of thing. So you need a valid methodology to address the question. And some of the things that I talked about before, like the topics I said, like case control study or cohort study or randomized trial or just observational study, these are the methodology which you would answer the question. And the type of methodology you choose depends on the type of research question that you want to pose, and also the time you have and the resources you have, right? But if you come up with a research question, then usually it's quite easy to decide that's either an observational study, or it needs a case control study, or it needs a cohort study, or it needs a randomized trial, right? It's usually quite easy to just, based on your research question, determine that. And then you need to decide what your what's called metrics of measurement are. What are the things that you're going to measure? And when you decide on metrics of measurement, you have to define them very clearly. I mean, some things, well, I'll go through this, but sometimes people think they're defining their metrics very clearly, like they want to measure weight or they want to measure height. But again, it's got to be weight in kilograms to 2 decimal places, or weight in grams. Yeah. So you have to define the metric very clearly, right? Height in centimeters, or how you define treatment failure, for example, or how you define treatment success. These are things that before you do your study, you need to decide on what the metrics are and how you define them. You need to come up fairly early on with data collection forms. And I think most people, when they're doing their studies, they think of a problem or an idea, and then the next step probably is to try to design the data collection form, because much of the other things I've mentioned are required to design a data collection form. You need to decide on the things you're going to measure and how you're going to measure them. Right? They all come into the data collection form. For most research, you have to put through an ethics proposal. Funding is usually not something that you apply for in your DCH or your MEd projects, but you can if you need to. And most research, not all, but most research requires including or engaging other people, whether it's you're collecting data in the emergency department on children who present with gastroenteritis, and you therefore need to engage the nursing staff to identify when children come in with gastroenteritis. So don't just try to do it solely on your own, but also engage other people. Again, early on, you need to come up with a spreadsheet that reflects the data in the data collection form, right? So you've got an idea, you've got a problem or a question you want answered, you've got a data collection form that tries to answer that question with measurable metrics, and then you've got a spreadsheet that reflects that data collection form. I'll explain what that means, but usually we are using Excel spreadsheets, and it's quite easy to design. Usually if you designed your data collection form well, it's usually quite easy to design a spreadsheet that just reflects your data collection form so that it's easy to enter your data, right? That's what you want. You want it to be an easy thing to enter your data and not be uncertain when you get to your entering data. Well, how do I enter it, right? All these things, if you think about them beforehand, it makes the study itself much better. And then you gather your data and you conduct the study and you develop an analysis plan. Again, that's quite useful early on, developing an analysis plan, because you need to, when you're gathering data, you need to know how you're actually going to analyze the data you're collecting, right? And that's usually based on the, trying to answer that question that you posed in the first place. And then you can commence writing. Now, you can write the introduction and the methods very early in this process. In fact, for your proposal, you'll have to write a short proposal, and you should think of your proposal as being just the start of your report or your thesis at the end of it, so that you don't duplicate things. You don't write a proposal and then write another funding proposal, or write one for ethics, and then start again when you're trying to write your thesis. You should, if you write the introduction well and the methods well, you usually need to modify them a bit, expand them a bit, but at least you've got some writing down on paper on your computer to start with, and because often people find the writing the very hardest part. I talk about this thing called dummy tables, and that's when you're trying to decide what the way you're going to present your data, then it's useful, even before you've got data, to think about the metrics you're going to present and how they might fit on a table, right? And you can mock up a table that is blank. It doesn't have any data in it, but it has the metrics, that it has the outcomes, the measurements you're going to measure, and the metrics. I'll show you some good dummy tables. But again, these are all things so that it makes the last part easy. When you've finished your study and you've got your data, then the analysis and the writing becomes easy if you've done all this preparation beforehand. Okay, it seems like a lot, but it doesn't have to be a lot. And for most of the studies that you'll do are mostly observational, but they can still be quite complex in the way you design and analyze them. And then you have to write your minor thesis, which is, again, I'll talk a bit about a minor thesis, but it doesn't have to be very long. This is important, that you can write a very good minor thesis of 2.5 or 3,000 words. Usually about 3,000 words is about right. Right? It doesn't have to be very long and extensive. You don't have to write 10,000 words or 50,000 words like a PhD or something. Just 3,000 words is quite good. And in fact, some of the best DCH and MMed theses have been written just like a journal article would be written. 3,000 words with a couple of tables, maybe one figure, plus references, plus abstract, right? And that's your thesis. Okay. All right. Now, so that's the research process and how to do a research project. We'll do a lot more talking about that as we go along, but I'm just going to talk now about epidemiology, and because that's really the basis of most of our clinical research. I don't necessarily mean just epidemiology, understanding patterns of disease, but it can be clinical epidemiology, understanding diseases that we see in the hospital, right? Or it can be public health epidemiology. But really, epidemiology is simply the study around people, right? Epi meaning around, demos meaning people, and logia meaning the study of or knowledge of the people. So it's really, you can also have, of course, veterinary epidemiology, but mostly what we're talking about is human epidemiology, right? And it doesn't have to be about health. Epidemiology could be about social factors or any political epidemiology. It could be anything, but mostly we apply it to health. And there's lots of types of epidemiology, and most of the projects that we do are like mostly descriptive epidemiology, right? Describing disease by time and place and person. You're describing disease patterns or different types of diseases, or you're measuring the burden of diseases, right? Now, some is a bit analytical, right? Beyond just descriptive or observational becomes something analytical. And that's looking for like associations between exposures and outcomes, looking for causes, looking for comorbidities that might influence outcomes, looking for outcomes. So the analytical ones, you're not intervening at all, but you're analyzing the basic data to get more than just a description of the population, right? Mostly we do both of these things. We describe the population and then we analyze it in some way. And many of those things that I talked about, case control studies and cohort studies, they're descriptive studies, but they have some analytical analysis too. That's why we have like means and medians, proportions and incidence and prevalence, right? They're all descriptive type statistical tools, and then analytical tools will be things like odds ratios or relative risk and that sort of thing. Yeah. Okay. And then there's interventional studies, and mostly we haven't been, for the masters and DCAs, we haven't been doing too many interventional studies like randomized trials. There's been a few that have been done, but not too many. They're not necessarily more complicated than other analytical studies like case control studies and cohort studies, but all of these studies, they need to you need to have thought through the methodology, right, very carefully, and you need to do it properly. Now, I guess increasingly people are also doing qualitative studies. So mostly the things I've talked about have been quantitative metrics, right? And we'll talk about how to do qualitative studies a little bit later, but many people are doing both sometimes mixed method studies where they do some quantitative and some qualitative studies, right? And epidemiology can be clinical. You can study a disease you're interested in, neonatal infection or tuberculosis or HIV, some aspect of each of those things, or it can be public health. So you might study, the environmental conditions that increase the risk of dengue or something like that. It could be a public health study. You might. We've had some very, very good, I think, both clinical and public health studies in recent years, because people have followed some sort of research methodology, and they've had a good question to start with. So much of the quality of research really is based on going through these steps carefully, I think. Yeah. All right. I'm just going to go back to the first sort of epidemiological study, and maybe this gives you some of you might have heard this story, I'm sure, but this gives you an understanding of what about what epidemiology can do and why it exists in some ways. But there was, like in many parts of the world in the 19th century, that's the 1800s, right? 150 years ago, more than that, isn't it? 150 years ago, about that time, there was a cholera epidemic in London, right? And this was happening all over the world, of course. Cholera was endemic in many countries in the world, but this cholera epidemic in London caused many deaths. And there was a scientist named John Snow who observed this observation between cholera deaths and the source of water. Now, of course, we know now that cholera is related to water. We know that cholera is a bacterial infection. There's so much about cholera we know that wasn't known in the 19th century. All they knew was that it caused diarrhea, and it caused people to get very sick very quickly and to die. But they didn't know it was a bacterial infection. They didn't know it was waterborne or anything like that. But John Snow realized that there were two water supply companies in London. One was called Southwark and the other one was at Lambeth. And they had public pumps, like pumps in the streets, and they would pump water. And the people that lived around the area where the Southwark pump was had a 5 times, you can see it's almost 6 times increased risk of cholera to those who lived in the villages where the Lambeth water supply was, right? So this is the cholera death rate per 1,000 population, right? So they were able to measure, again, this is a metric, a death rate, which is the number of deaths per 1,000 population, right? And you can see even from the map, this is John Snow's map, how there's a cluster around this pump, right? Or around this street, right? Broad Street, a cluster of cholera deaths. These are cholera deaths around in this area of London. And so based on that, in Broad Street, John Snow identified this pump, and it was the source of the outbreak for cholera. So it was the cause of the cholera. Remember, this is even before they knew cholera was waterborne or cholera was caused by a bacterial infection. And all he did was remove the handle of the pump. This is a famous thing that he did, which just means no one could use the pump. And then cholera deaths subsided, right? And so it was really by understanding the pattern of disease, the pattern of cholera in London at that time, that allowed this intervention, which was taking the handle off the pump to reduce the, to eliminate cholera or reduce cholera in that area, right? So so epidemiology can be very powerful if it's done well. And I think sometimes, this sort of mapping, is sometimes the best way to display epidemiology, depending on what your study is. But, you might think of a study, there's been studies done in years gone by about looking at the referrals to a health facility, referrals to a hospital. And the best way to display that is actually to map the cases. There was a study done last year looking at, yes, Whitney Rape did a study of typhoid in the Eastern Highlands, and she was able to map the cases that were all around Goroka and things. You know, it was a very nice way to study that. Yeah. So it's good to, sometimes it's good to just draw a map, you know, instead of doing a lot of writing, but draw a map very carefully. Again, that you have to think about that to start with. Yeah. I remember there was a study done of looking at referrals to Tari Hospital when paediatric services first got there, and mapping of where the referrals come from. That can be very useful. Years ago, Professor Frank Shan, you know, if you've heard of Frank Shan, he did a study similar, looking at all the referrals to Goroka Hospital, and was able to map the places where all these referrals come from. And of course, realized that most of the referrals came from the Goroka area, not as many from outside. That's not surprising. Yeah. Okay, mapping can be very useful. Right. Okay, so why learn epidemiology? Well, the main thing is to conduct your own research and make your own discoveries. But also, I think it allows us to be better doctors. To understand epidemiology, then we understand the patterns of disease we're seeing in the ward, in the hospital, in our district, our province, throughout the country. It's because if you learn epidemiology, you really have a good understanding of those public health issues, and you can. I always find it useful to think about what's the public health implication of the diseases that I'm seeing in the ward, right? We may or may not be public health physicians, but we can think about the public health implications of the diseases we're seeing. And then, you know, there might be, for example, I think the typhoid epidemiology that's being done in the Highlands at the moment, you know, should be really important, because it should enable us to, you know, make some intervention, whether it's the typhoid vaccine or whether it's a public health intervention. You know, there's got to be something done about typhoid, but it's got to be based on a good understanding of the patterns of typhoid throughout the country. And I think also sometimes just clinical epidemiology is to, you know, understand as clinicians, are we doing a good job? And even the most basic epidemiology, looking at the case fatality rates in your hospitals, you know, this can help us understand, are we doing a good job, right? So that's why it's crucial as part of pediatric training in most medical disciplines, regardless of what it is, to understand epidemiology. And that's why some research, a bit of research, is part of postgraduate training for all specialties. Right? I'm going to talk about some basic terminologies and today, and the ones I'll talk about are proportions, rates, and ratios. Right? These are jargon terms, but I want to try to describe them so you understand, and talk about incidence and prevalence. Right? If we get time, we'll talk about means and medians, and interquartile ranges, and confidence intervals and Z-scores. But I really want to aim to get past the first part first, right? Because when we're talking about these are descriptive terminology. If you're describing your population, in any study you do, you'll have a study population. It'll be children or neonates or whatever of some. There'll be a population, and you have to describe your population in ways that are valid and make sense, right? Okay, right. So let's talk about rates and ratios and proportions, right? Well, a proportion. How do you come up with a proportion? What's a proportion? Think about the proportion. Give me an example of a proportion. It's a fraction, yeah, that's right. And then think about a practical example of a proportion. Okay, but sorry. Well, it could be a particular disease, but you could. Children under 5 is a proportion of all children, perhaps. You know, it's a proportion of children up to the age of 18, let's say. What's the proportion of children under 5? Or what's the proportion of adolescents compared to the overall proportion of children? So that's a proportion, yeah. What you were thinking, a particular disease?
There's mild, moderate.
Yeah, that's true. Yeah. So in your ward, you might want to understand the proportion of pneumonia cases that are, moderate or severe, moderate cases or severe cases. You could do that. Yeah, that's true. So a proportion is just um, uh, a subgroup within an overall population, and looking at that as a ratio. It's a fraction, right? It's a fraction of the population, right? Now, the difference between a proportion is a ratio, but the other some ratios where the um, the number of children, say children with severe pneumonia, are also children who have pneumonia. Does that make sense? They're the same sort of population, right? There are some other ratios that are still one number divided by another number, but the numerator is not necessarily included in the denominator. So when we talk about the maternal mortality ratio, what's that? That's the number of
dying during childbirth or after childbirth over the total number of.
It's live births, isn't it?
Yes.
It's live births. So the number of women who die during childbirth or pregnancy or in the immediate postpartum period divided by 100,000 live births. That's the maternal mortality ratio, right? And in that ratio, the numerator is not really included in the denominator. Obviously, they're related, but they're not really included. That's an unusual sort of ratio, perhaps, where there's a difference between the numerator and the denominator. But in the infant mortality rate, what's the infant mortality rate? Sorry? It's the number of deaths in what, though? Infant mortality rate. Remember, the numerator has to have a definition. It's the number of deaths up until the age of 1 year, isn't it? Yeah, 1 year divided by 1,000, every 1,000 live births, right? So that's a infant mortality rate, right? Sometimes the rate, not always, but usually has a time dimension. So it's a rate over a certain period of time, right? So the incidence rate of measles in an outbreak, right? It has a dimension of time during the entire outbreak, right? Or the infant mortality rate. The infant mortality rate changes, doesn't it? But if you look at the infant mortality rate over a year or over a 5-year period, that will tell you what the that's why it's a rate. It usually has a time dimension. There's many ways to measure mortality, and we've talked about some of those. So mostly we know about the child mortality rate. This is important both for learning about epidemiology, but also learning for your exams, because often the child mortality rate or the infant mortality rate, the neonatal mortality rate, they generally come up in the exam. So what's a child mortality rate? Yes, it's probably shouldn't be called anymore the child mortality rate. I don't think it should be the under 5 mortality rate, shouldn't it? Yeah. Because there are children who die, over the age of 5, right up to the age of 18. But mostly up until recently, we've only counted under 5 deaths. But I think increasingly there's reasons why children, get sick and die in school ages as well, for chronic illnesses and that sort of thing. But the child mortality rate is the number of children who die up to the age of 5 per 1,000 live births, isn't it? Yeah. And the infant mortality rate, we talked about the number of deaths in children up to the age of 1 year per 1,000 live births. The neonatal mortality rate. What's that? Yes, within 28 days of birth, isn't it? Yeah, that's right. And the perinatal mortality rate, that's a bit different. What's that? No, 1 week. Within 1 week of birth, or stillbirths, or within 1 week of life. Yeah, yeah. So early neonatal mortality plus stillbirths, isn't it? Stillbirths plus early neonatal mortality. That compromises the perinatal mortality rate. Yeah. And the stillbirth rate's obvious. They're stillbirths, right? We say obvious, but actually sometimes that's mixed up. But that's clear. And then the maternal mortality ratio, which we've talked about per 100,000 live births. So most of these other ones that relate to children are out of 1,000 live births, and the maternal mortality ratio is out of 100,000 live births. Can you think of a reason for that? It's just about frequency, that there's more frequent stillbirths and neonatal deaths and child deaths that it makes sense to make it out of 1,000, whereas maternal deaths, should be much, much lower. And so if it made it out of 1,000, it would be like a fraction, in many places, it would be a fraction. Whereas for out of 100,000, then it's a whole number. That's all. Yeah, yeah. Okay, right. So that's population-based mortality measures, right? Remember, we've used the word metric, and that these are just metrics, aren't they? They're metrics because they have a definition that allows you to know what the numerator is and what the denominator is, right? And then we have health facility-based rates of mortality. And often these two are confused, right? The health facility ones are the public health ones, but health facility-based mortality rates are usually called case fatality rates or case fatality proportions. And these are often what we look at these often. And so this is from the PHR, from an older version of the PHR, but this is the sort of output. And this is from, well, it was Kundiawa from some years ago, about 10 years ago now. But you can see these are all case fatality proportions, right? So I want you to be clear about what that means. It's the number of deaths divided by the number of cases of that particular problem. And that gives you a percentage, right? Doesn't it? It gives you a percentage. If you multiply it by 100, it gives you a percentage, right? Or you can just leave it as a proportion, right? A percentage and a proportion are the same thing, right? But you can see that I just want you to look at the most extreme percentage there. So the total in that year for Kundial was 7.1%, the total case fatality rate. For pneumonia, it was 5.9. For severe pneumonia, it was 14. Right. For anemia, it was 23.9. So very high case fatality rates for anemia. Tuberculosis, 11. And extrapulmonary TB had a higher mortality rate than pulmonary TB. We see that regularly, right? And then very low birth weight, it was very high case fatality rate. So from knowing these data, one, you can benchmark with previous years, and you can benchmark with other hospitals about why there are differences in case fatality rates, and you can follow these over a long time, as we have done and seen. Well, since 2013, the case fatality rates have fallen in almost all hospitals, right? All hospitals' case fatality rates have fallen. Now very few hospitals would have a case fatality rate of 14 for severe pneumonia. They're generally quite a bit lower than that, around about 10. And many hospitals have much lower, very low birth weight case fatality rates. Usually it's about a third, isn't it? About 35%. We're not surprised if it's that, right? So, and the overall case fatality rate usually is around about 5%, maybe 6%, but 7% is quite a bit higher. Yeah, because remember, this is looking at large numbers of children. So we measure these things so we can benchmark and assess our own performance and and then compare that with other hospitals as well. Now, just because one hospital has a higher case fatality rate than the other doesn't mean they're not doing as good a job, because that the hospital with the higher case fatality rate might actually have children that are much sicker, right? Maybe they come from a long way away, or maybe they're more of a referral centre, so they get the sickest patients coming in. There's lots of reasons that aren't just about, are you doing a good job or quality of care? But knowing these data helps you understand them. It helps you understand whether, your case fatality rate is much lower than others, and why they differ, or why they might have increased or decreased over time, all of these things, yeah? Okay. As well as mortality measures, we often have like morbidity measures, and I'll talk a bit more about these, but there's measures of prevalence and measures of incidence, right? They're measures of morbidity, usually, prevalence and incidence, right? And we might also measure like the number of hospital admissions or hospital discharges. They're just measures of morbidity, right? Or the number of clinic consultations for children with a particular disease. That would be just a morbidity measure. There's a couple of other like more complex morbidity measures that you'll probably hear about. You've probably heard about, like people measuring quality adjusted life years. Does anyone know what that means? Or disability adjusted life years? It's the way people measure, let's say you have what do I say? A child who has meningitis, right? A child with meningitis, and we know that the mortality rate from meningitis might be about 10 to 15%. Most years it's about 10 to 15%. That's the mortality rate. But what we're not measuring in that is what the long-term morbidity rate is. All right, we don't, if you look at those children who have meningitis, then at least another 25% have significant neurological impairment, right? Either they have deafness, or they have cerebral palsy, or they have epilepsy, or blindness, or some other problem, right? And so a way of measuring that people come up with is this thing called disability adjusted life years. You don't need to know this, so I think I find it very complex myself to try to understand that. But when people look at the overall disease burdens of different diseases, if you have a disease that you get over quickly and you're well afterwards, then that has a much lower loss of disability adjusted life years, right? Whereas if you have a disease that's like meningitis, then of course some children respond and they're well afterwards. They don't have any disability. But for those that do, you can't just count the deaths, but you also have to have some measure of the children, the burden of the disability. That's really what it is. It's trying to measure the burden of disability. And it's not just neurological disability. There's disability adjusted life years are calculated for like coronary artery disease or cancer, where people live with the disease for a long period of time, and they're not the same as what they were before they had the disease. They're not as well. And so therefore they have some measure of disability, right? Whether it's in whatever it is. There's another one that's very similar called quality adjusted life years. It doesn't again, we won't be using these metrics, but just to know they're there, because people use them, and they've been validated and everything. Yeah? Other useful measures we might measure, for example, with TB patients, we might measure treatment completion rates, right? That's not a morbidity. It's not a morbidity measure. It's not a mortality measure. It's actually in some ways like a health service quality measure, isn't it? We're measuring how well we are doing at completing treatment for children with TB. Or we might measure adherence rates in children with TB or with HIV with the antiretroviral therapy. So measuring, these are easy to say and actually hard to do. It's actually hard to measure an adherence rate, right? And even measuring a treatment completion rate is hard, because many of the patients get discharged from a hospital and they get their treatment at a health centre, and they get lost to follow-up by the hospital. It's hard to know just how many complete their treatment that you actually put on treatment. Same with adherence rates. It's actually quite a hard thing to do, because, people's recall is not always accurate. You know, it's not always possible to look at their, you know, pill counting and that sort of thing, but there's different ways that people have done it, mostly with pill counting, isn't it? Yeah. For some medications, you can combine pill counting with like just looking at the urine and measuring the drug in the urine, for example, looking to see if the child's got, you know, red urine from rifampicin or something. That can augment your understanding of adherence. Yeah. Right. And then there's other morbidity measures called like event-free rates. So, you know, for diseases like leukemia, then we have a 5-year survival rate, don't we? Yeah. If you're clear of leukemia for 5 years, then you're effectively cured, isn't it? But so what we try to measure is 5-year relapse-free rates, right? 5-year relapse-free rates for children with leukemia. And you might measure, for example, in children with epilepsy, seizure-free rates. Okay, we know the, you know, mortality rates are fairly low with children with epilepsy, but a good aim might be to measure seizure-free rates. Dr. Kaspari-Amon did that in her study that she did on epilepsy some years ago. A very good study looking at a whole range of things about childhood epilepsy, but one of those was, you know, whether or not she could, with better management, could get seizure rates down in these patients, and she was able to measure seizure-free rates in these children with epilepsy. We also, it's a relatively common measure, but measuring literacy rates in children, yeah. So you might measure that. There's, you know, those things. Yeah. Okay, right, now I'm going to talk about incidence and prevalence. And sometimes we mix the two up, but it is possible to understand what the difference is and try to use the word in an accurate way, right? So the prevalence is the number of people with a disease, right? At a given time, right? So if you want to know the prevalence of pneumonia in the ward, right? Right, the prevalence of pneumonia in the ward, then you can just, well, tell me the metrics for that. What's the prevalence of pneumonia in the ward?
Total number of children diagnosed with pneumonia.
So total number of children who have pneumonia, right? It's different to those who have been just diagnosed with pneumonia. So if you looked on any given day, right, of the number of children with pneumonia in your ward, then that's the prevalence of pneumonia in your ward, or the proportion of children with pneumonia in your ward, right? But mostly when we use prevalence, we're talking about, like, it's usually a population-based thing. It doesn't have to be, but if you think about the prevalence of a disease, like the prevalence of TB in the community, right? That's different to the incidence, because the incidence is the number of new cases of a disease occurring over a specified time, right? Usually when we think about TB burden of disease, we're thinking about the incidence, the number of new cases that have been diagnosed over a certain time, right? That is different to the prevalence. But if you looked at the prevalence within a community, there'll be many, many people that have not actually been diagnosed, right? So when we are thinking about some diseases, the prevalence may be much higher than the incidence, right? Because not everybody gets diagnosed, right? Okay. Now, so does that make sense? The difference between it? What incidence is the number of new cases, and prevalence is the number of cases that exist, right? Now, the reason why why we use the two different words is that some diseases are more appropriate to use incidence. With the incidence and the prevalence means two different things, right? For that given disease. So, like chronic diseases, for example, like diabetes, they have a very low incidence. How many people do you, or children at least, do you see, or let's say people overall get diagnosed with diabetes? Not that many, right? Not that many, right? Each week, for example, right? So the incidence of diabetes is fairly low. But if you looked at diabetes in the community, for example, if you did glucose tolerance tests on people within the community, you might find the prevalence is actually higher, all right? Because there's a lot of undiagnosed people with diabetes, right? It can also apply, for example, to a disease where there's where it builds up over time. So let's say rheumatic heart disease, right? The incidence of rheumatic heart disease might be relatively low, right? As compared with other diseases, right? But if you look in a community, because all the children with rheumatic heart disease, they might get better, but they've probably still got some rheumatic heart disease, so they will still have it. So they build up over time. So all the new cases from last year are included in the prevalence from this year. Does that make sense? Yeah, that's where it gets complicated. That say the incidence of colds, like an upper respiratory tract infection, is very high, isn't it? The incidence is very high, but because there's lots of people getting colds all the time, but the prevalence in that community might not be very high, right? Because everyone gets over their colds and then they don't have a cold anymore, so they won't be counted in the prevalence, right? Yeah. Okay. All right. So again, I talked a bit about this, but rheumatic heart disease is a interesting disease in that when we talk about incidence and prevalence, we're talking about two different types of the condition. So you can talk, if you're talking about acute rheumatic fever, what term would you use for that? What term?
Incidence.
That's incidence, isn't it? Because rheumatic heart disease is something you get, acute rheumatic fever is something you get and then you get better from, right? Afterwards, you might have rheumatic heart disease, but it's still something you get and you get better from. So if you're talking about a metric to measure acute rheumatic fever, you talk about the incidence of acute rheumatic fever. If you're talking about a metric to measure rheumatic heart disease, it would be better to talk about the prevalence of rheumatic heart disease in the community, right? Okay, right. I think it's obvious to you. Right. All right. I did touch on this a bit, and this is about TB incidence and prevalence and how they're different, and how what we usually do is measure TB incidence, and we don't know enough about prevalence. There have been some good studies looking at prevalence. I want to talk. I want to just go through one of those studies, but there have been some other ones. Mostly our understanding of TB is based on passive health facility-based screening, right? What does that mean? Passive health facility-based screening. Yeah, the patient has to come to us with symptoms, right? And then we make the diagnosis, right? That's passive. It's not passive on the part of the patient, but it's passive on our part, right? We are waiting for the patient to come to us, right? And that's a good way of estimating incidence, because it's the incidence of new cases that are diagnosed. But it's not a good way of estimating prevalence, right? Because, all the patients that don't come to us, right? And some in TB, particularly, patients don't come to the health facilities until it's too late. So in the health facilities, we see the most advanced cases of TB, right? Or until they've transmitted TB to many other people, right? So they've contributed to the prevalence of TB in their community, and we're only measuring one of them, right? But yet when they come, they probably transmitted it to many other people, right? And sometimes they don't come to health facilities because of geographical or educational or cultural issues, that, or because of it's just inaccessible, or because they don't understand what a health facility will do. There's lots of reasons why people with TB don't present to health facilities. So the incidence of TB at health facilities is not a good measure of the population burden of the disease, right? So in recognizing this, we did a study a little while ago, some years ago, where we looked at active case finding, right? And I think since then, this was 6 or 8 years ago, since then, there's been much more focus on the value of active case finding for TB, right? And I think many provinces are now doing active case finding. This was one of the first active case finding studies where we looked at community screening, like going to a community to identify the population prevalence, right? And so we had these, again, you have to have research questions. So the first question, in a way, many people said active screening wasn't possible in PNG, right? So the first question is whether or not you can have a simple model of active screening, of community-based screening, and it can be carried out in a very remote area. Is it feasible? Right? Because many people said it was not possible, and too costly. So you just wait for people to come to you, right? And then we wanted to know what is needed to achieve this. Like, what do you need to do active case finding, in terms of the method, logistics, and human resources and skills? And can it be done on a very low cost? We wanted to know, can it be done on a low cost? And then the most, I guess the most important question is, what is the yield? Like, what does it tell us that we didn't know before? How many new cases would you find compared with if you just wait for them to come to you? Yeah. And then can it be done at an affordable cost? And so we chose this area in Morribee province, and it's called ETEP, right? Some of you might have known it or been there, maybe even. And it's a remote rural area. And the reason why we chose this area was because there was some doctors at this mission hospital, ETEP Rural Hospital here, and the thing they'd noticed was that there was many children coming in or adults with abdominal TB, right? They would get so many people being diagnosed with abdominal TB that they wondered if there's something unusual about the population, right? What do you think that tells us? If we see a lot of extrapulmonary TB in our clinics or in our hospitals, what does it tell us?
Yes, active pulmonary TB, like related to that is residing in the house that is popping up, and that's more children may need what I just see.
Yeah, it tells you, like, if you're seeing more extrapulmonary TB than pulmonary TB, it tells you there's a lot of pulmonary TB you're just not seeing, because people think cough is normal, right? They think it's normal, or they don't worry about it, right? But they come in, they've got big ascites, they'll come to hospital, right? So I think that's an interesting. This was the basis on which this study was done, because of all the abdominal TB that was being seen at ETEP Hospital. And so what we decided to do was to do active screening in all of these areas, right? So there was 2 districts, the blue districts and the green district, and we did active screening in all these areas. And what did active screening mean? Well, again, people thought it was logistically impossible to do. We decided to do it in a very simple way, and that is you go this was the active screening program. And what we did was first of all, we informed the villagers that we were coming, and that this was what we were trying to do, to try to find people who were unwell in any way with respiratory infection, mostly respiratory infection. And what we wanted them to do was to screen their population beforehand and just everyone identify people who've got any respiratory disease at all. It doesn't have to be TB. And they came for sputum smear testing, right? We didn't have x-rays, we didn't have gene expert test. We just had on-site sputum smear testing with Zeal-Nielsen staining. And so the microscopist had Zeal-Nielsen staining, and all these people lined up to be tested. For the children, we did screening, just symptom-based screening, right? And clinical signs-based screening, because mostly they don't cough up, right? Yeah. So that was very simple screening, not with sophisticated tests. Nowadays, they're talking about doing active case finding with mobile x-rays and that sort of thing. But this is quite simple. It can be done, as you can see, this technician was able to do the sputum smear testing just on a bench in the village, and we just had people lining up to be screened. And so in the population area, there were 70,000 people in those areas, and the villages themselves selected 17,000 people, right? And of those 17,000 people, there were 20 in that area. There were 26 villages selected, and there were 17,000 people within those 26 villages who were not. 1,700. So 1/10 of those were nominated as having some symptoms on screening. So we had to screen with sputum smear testing 1,700 people, right? And of those went through a further clinical screening, like a questionnaire, a simple questionnaire, and then we did sputum smear testing on 230 people. And of those, we found 98 who had pulmonary TB. So very high yield, 98 out of 230 people. Now, of course, some people might have been sputum smear negative and still had TB. Some people might have not had pulmonary TB, but had other symptoms, but we also screened for other extrapulmonary symptoms, right? Now, of those who were suspicious for TB, 15 had extrapulmonary TB, 98 had pulmonary TB, and there were 17 children with TB just based on clear symptoms and clinical features, right? So then from that, you can come up with a prevalence of TB within the communities. Remember that the source population was 17,000 people in those 26 villages. So the source the prevalence then becomes the number of people, the yield or the number of people with TB, 130 people with TB out of the source population. All right. And so you can calculate what the population prevalence is. So maybe if you've got a calculator, calculate the population prevalence and the prevalence per 100,000 population. Because usually when we talk about TB prevalence, we're talking about a prevalence per 100,000 population. Has anyone got a calculator and could do that? You can calculate like a percentage, and you can calculate the prevalence per 100,000 population. How would you do that? What did you get? Yes, that's right. Yeah, 765, I think it is. But yeah. So if you do like 130, which is the numerator, which is the number of people who were diagnosed with TB in the population or had TB in the population, divided by 17,000 times 100, that gives you the percentage of it, 0.76%. Now, again, remember I said that mostly when we're talking about TB prevalence, we're talking about the number of people with the disease per 100,000 population, right? And so if you multiply it by 100,000, exactly like you did, Dasha, you get prevalence per 100,000 population, 765 per 100,000 population, right? And so I'm not sure whether you know, but that's a very high prevalence, right? Very high. It's not quite 1%, but it's nearly 1%, right? And that's very high to have that, right? There has been another study that was as high as 1.2%, actually, 1.2% or 1,200 per 100,000. But this one in ETIP, 765, that's very high, yeah, TB prevalence, right? Now, remember I said that one of the things we wanted to do was to work out whether or not the whether it was cost effective, right? Is it a cost effective way to do screening to identify people with TB? Well, it cost us 56,900 kina. That's what it cost us to do this screening. It took several months, right? It cost us that much money, but you can work out, like, is it worthwhile? Well, the cost per case was 130, that divided by 130, right? And that comes to 438 kina. So for 438 kina, you can find one case of TB that you didn't know about in a remote area, right? So is that cost effective or not cost effective? I think it's very cost effective. And I'll tell you why. Because if you think about what do TB drugs cost, right? TB drugs for the basic treatment, they're relatively cheap, right? And so you can get patients onto TB medicines, right, quite cheaply. If you don't treat them, then they get complications, they get advanced TB, they might get MDR TB, right? And MDR TB treatment drugs are very expensive, right? Or hospitalization is very expensive. So if you're finding patients early and treating them early, then it's much more cost effective than actually having them in a hospital for 6 or 9 months. I don't think we know here just what it costs to have a patient in hospital, right? But in many countries, they've done these analyses of what it costs to have a patient in hospital. It's at least this much per day. A day's hospitalization would cost you this much. When you consider all the cost of the doctor's wages, the nurse's wages, the equipment, the drugs you're using, the cleaning staff, the, facility upgrades, everything. If you think about that, hospitalization is very expensive. So if you can find patients in the community and put them on TB treatment, then it's much more cost effective than finding them only when they present, right? When they're sick enough to present and then treating their disease. So there you go. That's active case finding of TB, and it's an example of the value of understanding population-based prevalence and not just being satisfied with hospital-based incidence. Yeah. Sometimes hospital-based incidence is right for some diseases, but not for TB and other chronic diseases. Right. I wanted to say something else about prevalence. There are different sorts of prevalence, right? And it depends on what question you ask. All right. This is important because, when you're designing a questionnaire, right, then you might ask about a particular disease, right? These are not correct. I want you to try to put them in the correct order, right? So, do you currently have asthma? What sort of prevalence is that? Do you currently have asthma? Point prevalence, isn't it? Right today, do you have asthma? Right? That's what point prevalence is. Have you had asthma during the last 2 years? What sort of prevalence is that? Period prevalence, isn't it? That. And have you ever had asthma? Lifetime cumulative prevalence, isn't it? So if you had asthma when you were, 6 and you're now 35, then you would say yes to that, but you wouldn't say yes to the other two. Yeah. So depending on how you ask the question, there are different sorts of prevalence, right? Does that make sense? Yeah. And it's important. So you've heard of the demographic and health surveys, the DHS, they ask certain questions about childhood illness. So for example, they ask questions about like acute respiratory infection and about diarrhea. And do you know what the question they ask? Most of us have been part of a census or part of a DHS. What question do they ask the parents? About diarrhea. Well, they ask, has your child, not has your child got diarrhea today, but they ask, has your child had diarrhea in the last 2 weeks? That's usually the question about acute illnesses, right? Acute childhood illnesses. So has your child had cough and fever in the last 2 weeks? And there's a reason they ask about the last 2 weeks. Well, what would that be? It's just about recall and our memory. Yeah, we won't necessarily remember if our child had, a cough, a month ago, but we'll remember if they had it in the last 2 weeks. It increases the precision, I suppose, of the measurement. That's all. So it's over 2 weeks. So that is a period prevalence, a very short period, isn't it? But it's a 2-week prevalence. That's all. Yeah. Yeah. Maybe when we talk about other, studies and how to design them, there have been some good studies, what we call point prevalence surveys, right? Clinical studies of point prevalence surveys, where you might look in the ward at any one time to see perhaps how things are going or what's being done or the way conditions are being managed. And that's a point prevalence because you're looking at a cross-section in time. And then you might look later on. For example, I haven't given an example, but for example, like adherence rates to like antibiotic guidelines, let's say, you can measure that in a ward at any one time, right? And you might measure it at one time and then come back a few months later and measure adherence rates again and see if that changed. And maybe in the middle, you might do some intervention, right? And that's what's called a point prevalence survey, right? The point prevalence survey is just measuring it on one occasion, but some people have done studies where they've measured it 2 or 3 times to see if anything changes over time, right? That's a point prevalence survey is quite a good way of doing a study in a relatively short period of time to give you some useful information, right? Dr. Michael Landy did, I think, one of the best point prevalence surveys that we've had done, and that was on the management of severe malnutrition. I don't know whether I sent that on to you, but I'll try to. That was published, and it was on the management of severe malnutrition in this hospital. And he did point prevalence surveys looking at the many different aspects of the management of severe malnutrition, just over a 48-hour period. And he looked at every patient in the ward who had severe malnutrition and the way they were being managed. And doing point prevalence surveys like that enables you to explore lots of different types of issues in a short period of time, right? And then he did some follow-up teaching and introduced F75 and F100 and ways to measure better and guidelines on the ward round trolley, and found that all of those things got so much better and children gained weight so much quicker. But again, he was just, instead of doing it like for 6 months and measuring every child, it's very taxing. It's very hard to do. He just did it in 48-hour epochs, whereas he captured every child in that 48-hour period 3 times over a year, right? And so that's an efficient way of doing research. Yeah. Right. So the right answer is, of course, this. Okay, point prevalence, period prevalence, and yeah. All right. Okay. I might stop there. That's the end of lecture 1, if you like. That's what we're 1/5 of the way through. The second lecture is quite more detailed, so I'm going to just stop there. But next time we'll talk about means and medians and confidence intervals, and we'll go into. I talked about a observational prevalence study of TB, but we'll talk about case control studies and odds ratios in the next lecture. So I'm going to stop there and stop the recording.